Welcome to the Editor's Podcast for the Journal of Public Health Management and Practice. Editor-in-Chief Dr. Lloyd Novick will discuss timely and relevant articles that are featured in this month's publications. In alignment with an upcoming supplement on lead, Dr. Tim Dignam from the Centers for Disease Control and Prevention joins Dr. Novick to discuss the public health issues associated with lead exposure trends in the United States. Welcome.
Thank you.
Thank you. Our January supplement, which publishes in early December, is on the subject of lead poisoning prevention, certainly a very important topic for those in public health and for those in many communities that are afflicted with this problem. I have a few questions to ask this afternoon to get us started. And the first question is that overall, U.S. population blood levels continue to fall. How have national policies aimed at controlling sources of lead exposure contributed to this trend?
Well, thanks for your question, Lloyd. There's been several U.S. policies that have contributed to declining blood lead levels. The most notable began in 1971, which was the Lead-Based Paint Poisoning Prevention Act, and it defined paint chips as the primary health hazard of lead-based paint, and it set the level of lead in blood warranting concern at 60 micrograms per deciliter. And this was followed by the phase-out of leaded gasoline in 1973 and the ban on lead-based paint in residences in 1978. In 1986, lead was banned in plumbing, and in 1988, the Lead Contamination Control Act virtually eliminated lead in gasoline. And this act is notable because it also authorized CDC to initiate program efforts to eliminate childhood lead poisoning in the United States, and it created the CDC Childhood Lead Poisoning Prevention Program. In 1991, the Department of Health and Human Services released the document called Strategic Plan for Elimination of Childhood Lead Poisoning, and this document set forth a comprehensive agenda to eliminate childhood lead poisoning. In 1992, Congress passed the Residential Lead-Based Paint Hazard Reduction Act, or what we refer to as Title 10, and this document and act protected families from exposure to lead from paint, dust, and soil. In 1995, the Food and Drug Administration, or FDA, banned lead solder in food cans. And in 1999, the Department of Housing and Urban Development, or HUD, issued the Lead Safe Housing Rule to protect young children from lead-based paint hazards in federally assisted housing or when federally owned houses are sold. And then in the 2000s, EPA issued the Lead, Dust, and Soil Hazard Standards that applied to housing built before 1978 and certain child-occupied facilities. In 2001, the Consumer Product Safety Improvement Act established new safety standards and testing and certification requirements for lead paint in children's products. And then finally, in 2010, EPA's Lead Renovation, Repair, and Painting Rule, or RRP as it's known, it set up new requirements for contractors who work on pre-1978 housing, and so they would do so in a safe manner.
Well, you've certainly described CDC and its partners' long-standing war on lead. One of the things that's interesting about this is that these efforts have continually narrowed guidelines for safe blood levels. When I began my career in public health, the acceptable lead level was a lot higher than what we accept today. For example, the 1971 Surgeon General's report defined undue absorption of lead as a blood lead level of 40 micrograms per deciliter and blood poisoning as a blood lead level greater than 80 micrograms per deciliter. Today, we understand there is no safe level of lead in children. Tim, can you comment on that?
Yeah, Lloyd. CDC has defined the criteria to interpret blood lead levels in children since 1975. And the blood lead levels for taking action have continued to decline, as you mentioned, from greater than 60 micrograms per deciliter in the 1960s to 5 micrograms per deciliter or higher in 2012. And that is the reference level that we use today. In 1995 and 1996, elevated blood levels became the first nationally notifiable non-infectious condition, and this resulted in vastly improved surveillance of the topic. And because no safe blood level has been identified in children, we at CDC, we continually and with our partners strive to prevent any exposure, and it's what we call primary prevention. Any downward shift in the criteria to identify lead exposure in children will allow practitioners in the future to identify more children exposed to lead and then refer them ideally to recommended services. In 1970, it was dropped down to greater or equal to 40 micrograms per deciliter, and that terminology was called undue or increased lead absorption. And similar terminology was used in 1975 when it was lowered to a range of 30 to 70 micrograms per deciliter. In 1978, the terminology changed again, and it was called elevated blood lead level, and it was 30 micrograms per deciliter or higher. In 1985, as the research continued, elevated blood lead level was still used, and it was set at 25 micrograms per deciliter or higher. In 1991, CDC, in their document called Preventing Lead Poisoning in Young Children, a statement by CDC, changed the terminology to level of concern, and it was set at 10 micrograms per deciliter or higher. And then today, in 2012, we still use the 2012 reference value, which is the level of 5 micrograms per deciliter.
At the current time, what sources contribute to the high risk of lead exposure in children? What are some of the more localized sources of lead that we do not traditionally think of?
Lloyd, the major sources of lead today in the child's environment are generally lead-based paint, and that can come from peeling and chipping leaded paint or dust when the child has traditional hand-to-mouth behavior at the early ages of 1 and 2. For example, lead paint disturbed during renovation of older housing can lead to lead-contaminated dust and also soil, and then the child is exposed in that manner. The Flint experience in Michigan reminded us that there is also lead in older drinking water systems and in pipes. And then more localized sources of lead include industrial activity, such as active mining and smelting. And then the non-traditional sources that you allude to of lead they vary greatly, but some examples include lead in spices, imported toys, cosmetics, and traditional or Ayurvedic medicines used by some ethnic groups.
You mentioned the Flint water crisis, and certainly the problems with drinking water are broader than just with Flint. For example, recently there was a news report about drinking water in Detroit schools. Can you comment further on some of the new issues that have been brought to light as a result of the Flint water problem and similar problems in other communities?
Sure, Lloyd. The Flint water crisis highlighted the need for many things, including targeted risk communication strategies, improved environmental health infrastructure, obviously, enhanced surveillance to identify and respond. So Flint definitely, got the United States attention, and and this attention on childhood lead exposure has resulted in additional support for CDC's Childhood Lead Poisoning Prevention Program. And CDC has used the additional funding to expand lead poisoning prevention activities with a goal to reestablish a robust national program that supports the states and the territories, the tribal and the local efforts to conduct blood lead surveillance and support referral systems for appropriate follow-up services. And obviously at the core of all this is to implement prevention activities. Additionally, the sustained community involvement in Flint, intense media attention, and strong advocacy and federal coordination efforts led to the WIN Act, which is the Water Infrastructure Improvements for the Nation Act, and this was authorized in 2016. And it authorized HHS to more thoroughly respond to the drinking water crisis. The Health Resources and Services Administration, or HRSA, received $15 million to expand their Healthy Start program across the United States, and CDC received $35 million to establish a new federal advisory committee, enhance childhood lead poisoning prevention program activities, and support the development of a voluntary Flint, Michigan lead exposure registry. And Lloyd, it's important to remember that many locations around the U.S., as you mentioned, have children with blood lead levels as high or higher than Flint. And increased attention to lead issues in the aftermath of Flint may have created the political will to eliminate lead in the environment, and social investment holds promise for public-private partnerships to help address the potential for lead elimination.
Another question, Tim, is to what extent do state and local childhood lead poisoning prevention programs apply the core public health functions to the prevention of childhood lead poisoning?
CDC's childhood lead poisoning prevention program is committed to applying the core public health functions, and those are assessment, policy development, and prevention. To address assessment, CDC monitors blood lead testing trends in blood lead levels over time via our national surveillance system, which is called the Childhood Blood Lead Surveillance System, or CBLS. And it serves as a repository for surveillance data submitted by state and local health departments. We're currently working with our cooperative agreement partners to incorporate geographic information systems and mapping techniques to identify high-risk areas and populations. And collectively, these data sets and tools help CDC and state and local programs identify who is being affected by lead exposures and where they live, so resources can be targeted where they will be most impactful. For more than 40 years, CDC has developed and disseminated reports on trends in blood lead levels and testing and other information that continues to chart the course for future lead poisoning prevention strategies and activities. For policy, CDC develops and disseminates guidance and recommendations aimed at helping state and local agencies fulfill the mission of identifying and protecting young children from lead exposures and its adverse health effects. CDC also convenes experts from among federal partners, academia, nonprofits, affected communities, and the general public, including parents of lead-exposed children, to advise the CDC program and make evidence-based recommendations that also consider the practicalities of real-world implementation. The former committee, which was called the Advisory Committee on Childhood Lead Poisoning and Prevention, or ACLIP, it made important contributions to CDC policy development on topics such as establishing the blood lead reference value, reducing children's lead exposures from imported products, and things like that. CDC has also recently participated in cataloging the key federal programs to reduce childhood lead exposures and eliminate associated health impacts that enabled increased coordination and collaboration among federal agencies. And CDC is currently collaborating with other agencies to develop a comprehensive federal strategy to reduce childhood lead exposures and health impacts. By identifying clear goals, objectives, and actions, federal agencies can more easily work together and identify priorities to improve children's health. Additionally, CDC is in the process of establishing the Lead Exposure and Prevention Advisory Committee, or LEPAC, to review research, federal programs, and services related to lead poisoning and to identify effective services and best practices for addressing and preventing lead exposures in communities. And then the last topic that a public health function is considered is assurance. And the way that CDC supports that is through its funding of state and local public health agencies to strengthen their capacity to engage in primary and secondary lead poisoning prevention activities in high-risk areas and population. And CDC's role is to provide technical assistance to these agencies to assist with carrying out federal policies and recommendations at the state and local level. In recent years, CDC Cooperative Agreement Award recipients have been primarily responsible for oversight of blood lead testing, surveillance, and public education and outreach, and for ensuring that environmental and clinical follow-up for children with elevated blood lead levels occurs.
A final question, Tim. What role do socio-demographic and geographic disparities play in achieving the Healthy People 2020 goals of reducing blood lead levels and differences in risk based on race and social class?
Data show that non-Hispanic Black children and those living below the poverty line are more likely to have elevated blood lead levels. And these children are also more likely to live in older housing with lead-based paint hazards. In addition to the disparities by race, ethnicity, and poverty status, we also know from blood lead surveillance data that many locations throughout the United States have significant pockets of lead-exposed children. For example, New York City, Chicago, Los Angeles, Miami, just to name a few. CDC's Childhood Lead Poisoning Prevention Program data can help identify high-risk populations and geographic areas so targeted interventions can be developed to reduce these disparities. Additionally, although all Medicaid-enrolled children are required by law to be tested for lead at ages 12 and 24 months, not all of these children are being reached. And this presents an opportunity for CDC to collaborate with the Centers for Medicare and Medicaid Services, or CMS, at a high level to ensure that testing of these high-risk children does actually occur.
Thank you for all of this information about this childhood problem. And also, I want to repeat again that within the next few days, a January issue of the Journal of Public Health Management and Practice will be out, and there will be an accompanying supplement on lead toxicity prevention, which will go into depth on a number of the issues that we have just discussed and additional issues. So thank you again, Tim.
Thank you, Lloyd. I really enjoyed my time with
Right.
All issues and supplements for the Journal of Public Health Management and Practice can be found at journals.lww.com/JPHMP. In addition, this podcast and others can be found at JPHMP Direct, the companion site for the Journal of Public Health Management and Practice.